got lots of different ways in which the rising cost of care is being managed. And orals have certain tools that can be worked with from a payer solution that really don't apply to infused drugs. And so we've seen them, and not so much in oncology. Obviously, prior auth is pervasive across all diseases. But in other diseases where you see a lot of high-cost biologics, like rheumatologic diseases, step edits, drug tiering, we're seeing different mechanisms to address it. Is it, for oncology, were there not enough orals to make it a prudent choice? Was it that it's politically incorrect? Why do you think payers haven't really moved yet into that, and are we there?
Well, first, I think in many states, at least 26 states, there are mandates to cover drugs. That doesn't mean that we can't manage them, but I think there's just that fear of being in the court of law or in the court of public opinion in the press that's made us demure. But I would say that we're moving in that direction slowly, where we're more willing to manage the therapies, to provide oversight. I think that the number of strategies that we have include making sure that patients for a drug that has a molecular marker, that molecular marker is indeed present. For drugs that are oral, 2-week fills, our data shows that 28% of people who are started on an oral medication, oral cancer medication, don't refill it.
So oral cancer medication specifically?
Right. Don't get a second dose, whether or not that's because of toxicity.
What's that percent again?
28%.
20% of cancer patients on an oral don't get a refill?
After a 14-day fill.
After a 14-day fill?
Yeah.
Wow. Is that surprising you?
Yeah, that seems high to me, but I can't say I've ever tracked that number.
Yeah. So that's one way, and it saves half the cost of a monthly prescription. But then every month you have that probability that a patient will stop the therapy. So it's a small savings, but we're looking for incremental savings. And I think we've moved in the direction of having preferred agents. In prostate cancer, we have a preferred agent. In CML, we have preferred agents.
Well, you do have a preferred agent now in CML?
Yeah.
And how is that distinguished for the provider? What's that difference? Is it difference only for the member who's going to have a different copay, co-insurance, out of pocket, or is it difference at the provider level?
Well, it depends on the disease state, and this applies for all diseases, but now we're applying it to cancer too. Sometimes we have step therapy. In prostate cancer, we have step therapy unless you can't take the preferred agent. In CML, we have step therapy as well. In other conditions, we just say this drug may produce a better outcome, but it's significantly more costly, so it's going to be on a higher cost tier. The member can still have it as first line or whatever indicated line. They don't have to step through, but there's going to be a greater out-of-pocket cost sharing.
Yeah. So we talked about the fact, and I'm getting into this because of this question that you just brought up with step therapy, and it brings up generics. And so we have biosimilars that is going to impact the infusion world, but again, most of these small molecules are chemically synthesized.
Right.
And so like Gleevec, they will be a generic. Now, you may not be seeing quite the degree of savings that you would have hoped to see in a generic, but there's still some. So do you see generics applying to those rules as you start to create them in these different conditions?
Yes, I absolutely do. I think we're going to lock out the branded drugs for new patients, and at some point I think we'll lock them out completely and force a mandatory switch, especially in an AB-rated generic space.
We've got initial lead, at least from the FDA and the way they applied the generic version of Remicade, that it was pretty broad.
The biosimilar?
As a biosimilar.
Yeah.
I mean, so I'm thinking when you talk about AB substitution, without a lot of data, and so is there concern there? But if the FDA makes the ruling, you're going to trust that?
I think we have statutory ability to, actually I take that back. I don't think we have a statutory ability to mandate the biosimilars, but I think we have the FDA standing behind us saying that these are equivalent and that they can be used in any condition. Now, we'll be even in a much stronger position for the biosimilars when we have an interchangeability designation. Then I think we'll treat that like an AB-rated designation.
So from the provider side, if it gets to be more scripted and this is the drug that you have to use first and it's going to be the generic version of the drug in the case of an oral, do you think there's going to be a lot of pushback? How do you feel that is a provider community as comfortable with FDA coming with a ruling and just going with it even when there's not a lot of evidence behind that?
Well, I'd say I think most doctors will be. We do use generic drugs for IV therapy, so I think there is some comfort level with using generics. And so this is just generics in a different form. And of course, we're used to using generics for non-oral oncolytics.
Yeah.
And getting back to those issues, you were surprised by the number on the split fill. Right. Do you see that as another impediment to being able to deliver good care to patients when you start the prior auth piece, which is a cost burden as well as a delay potentially for initiation of therapy? The split fill, I mean, these different techniques, which you understand the why behind them. Right. But do you see it as a potential burden both to the practice and to the patient, delays therapy, and do you have an alternative?
Well, certainly I understand, pre-authorization, and, as long as we're able to capture those scripts, at least we're able to recoup some of the costs that went into getting that pre-authorization. With split fills, that's a little bit more problematic for our pharmacies. Again, if it's kind of an even dose of 2 weeks, then a lot of times, if another patient comes in that's getting started on that particular drug, we can use the rest of that bottle, which is typically comes in a 28-day bottle, and give that to another patient. But some of these drugs.
So this is just the practical side of
right.
operationalizing it.
Yeah.
Because you've got carrying costs.
Yeah, exactly.
Right.
Or there are certain drugs, once you open the bottle, then you have a certain time frame in which that drug has to be used. If not, it expires, and that's wasted product, and that costs the practice money.
So we get back to the fact that you're a big believer that community site of care is a more cost-effective site of care.
Yep.
But again, there are policies here that make it more problematic for them to run their businesses, where they may depend on that revenue stream as ability for them to stay in community practice.